So hi everyone, this is Mickey Eisenberg. I'm glad you could join us on this Resuscitation Academy video cast, and it's a real pleasure to have with us today Sylvia Feder. And Sylvia is a paramedic at King County Medic 1. She's been a paramedic for approximately 30 years, and I'm very proud to say I have known you all of those 30 years. So welcome, Sylvia. Today's topic is on a program called Compelling Reasons, or another way to put it is dealing with end-of-life decisions. So I have some questions that I'd like to address directly to Sylvia, because she is the key person in this, having started a compelling reason program in the county. Boy, it's been at least 10 or 15 years, Sylvia. So let me ask you, even though we're all trained to deal with resuscitation, particularly in sudden cardiac death and in deaths for which the heart is too good to die, but what about situations in which it's time for death to occur? So tell me what made you start to want to improve end-of-life care. What was the motivation you had?
It was actually one call that I was on. And as you point out, as EMTs and paramedics and emergency physicians, we're all used to saving lives. And that's really our primary motivation and our primary focus. And that's what we teach the EMTs also. Even in my class that I teach on death and dying, I tell them that that should be their primary focus. But occasionally there's a call where you have to shift things. And in my case, it was a call for a gentleman who was dying of end-stage liver cancer. He was dying at home. It was an expected natural death. His family had not intended to call 911. And when he passed, his wife of many, many years told the neighbor, "Joe died." And the neighbor, not knowing what else to do, called 911, because that's what people do when they don't know what to do. And the firefighters arrived, and they came through the open door, and they found this gentleman emaciated. He had just recently died in a hospital bed at home. And they were obligated by their guidelines at the time to initiate a resuscitation effort. And the wife was sort of horrified, this isn't what we wanted. And they really felt that they had no choice in that matter. So when myself and another paramedic arrived, that was the scene. They were doing CPR on this gentleman who had died from an expected natural death. And the wife was just terribly distraught. And we stopped the resuscitation at that time. But it was clear that it was a very, very damaging thing to her. And so that really had a big impact on me. And I knew that it wasn't the fault of the EMTs. They were doing what they were expected to do at that time. But then a number of years later, when myself and another paramedic, Roger Matheny, were asked to help with a curriculum on death and dying for EMTs, we realized that there was this sort of dilemma of what do you do in this situation where a resuscitation effort is not wanted, inappropriate, and yet there's no written documentation, there's nothing formal that says that you are allowed to withhold a resuscitation effort. So that was kind of how I got into this whole issue around unwanted and inappropriate resuscitations, and what we can do about them as field providers, where we have to make quick decisions, and we often don't have that written documentation.
You come up with a very good name for this program. It's called Compelling Reasons. And what are the compelling reasons? How would you summarize them?
I guess I would say first, just to back up just a little bit about what are the times when EMTs and paramedics both, but the program is really focused on EMTs, is when can they legitimately withhold a resuscitation effort? And there's basically 4 reasons, and just very, very briefly, One is the person is physiologically beyond resuscitation. So they've got a long downtime, they have lividity. You can withhold a resuscitation in that situation. A second would be injuries incompatible with life. Fairly obvious. Third would be if they have a written do not resuscitate order, and that's different in every state, perhaps in every country. So people should be familiar with what their written do not resuscitate documentation is. But the fourth criteria by which EMTs in our system can withhold a resuscitation effort is what we call compelling reasons. And to invoke compelling reasons, two criteria have to be met, and they both have to be met. So one is that they have the end stage of a terminal condition. That's criteria number one. Criteria number two is that there is a request from the patient or the family that no resuscitation be attempted. And I want to talk just very briefly about those two, because I think those are important. The gold standard for any patient care is to honor the patient's wishes. And EMTs learn that when they're brand new, in fact, I think probably in their first day or two of lecture, that they can't treat somebody without their consent. So if they're driving their 8 car down the road and they see somebody who trips and falls and skins their knee, if they jump out and say, hey, can I help you? And the person says, no, that's okay, I'm fine. They can't grab that person and tie them onto a stretcher and treat them. They honor that patient's wishes. And as a society, we have begun to realize that people who are dying have the same rights as people who are alive. And if they say, I'm at the end of my natural life and I don't want to be resuscitated, that we should honor that request. So that's really the second part of those compelling reasons, that there's a request from the patient or the family that no resuscitation be attempted. We added the end stage of a terminal condition in there because we want to make sure that it's an appropriate request that no resuscitation be attempted. In other words, that it isn't a person who is clinically depressed, who could have a long life ahead of them, that decides that they don't want to live on this particular day. And we want to make sure that there isn't something nefarious going on. Those are exceedingly rare situations, but we added that end stage of a terminal condition to make sure that when a family or a patient requests that no resuscitation be attempted, that is a reasonable request, that everything fits, that it's a complete picture. So that's basically what the compelling reason says. And people who are listening might say, wow, that end stage of a terminal condition, that's kind of vague. And indeed, there is no bright line between what is terminal and what isn't. We're all in a terminal condition. But again, we put that in there to allow the EMTs a little bit of latitude, and we tell them, if you have any doubts, if something doesn't seem right, if it's not completely crystal clear, when in doubt, you should initiate a resuscitation, because you have lots of time to make a decision about stopping a resuscitation. You don't have much time to make a decision about starting. So if something doesn't seem quite right, maybe it's not quite a terminal condition that you don't believe it is, you think there's something funny going on, you should always initiate a resuscitation and let the paramedics, the other crews come in. It can be very challenging as the first in unit to have to make these difficult decisions. So if it's not clear cut, they should always initiate a resuscitation if they're in any doubt.
I think those are very well articulated reasons for such a program like this. But I want to make sure, does end-of-life care mean no care, or is there still care that can be given?
That is a great question, and that's something that we really emphasize to the EMTs is very early on. When I'm teaching a class on end of life, I say that do not resuscitate doesn't mean do not treat or do not care. There is still care that can be provided to a person, perhaps who's in the dying process, but who hasn't died. There's all sorts of comfort measures that the EMTs can provide to that patient in terms of positioning, opening the airway, suctioning. Even in rare cases, they may request a medic unit to assist them. They can bring hospice into the situation if the patient has been enrolled in hospice. So there's lots of things that can be done for a person who's dying. And care does not end when the person dies, because you have the family members and the friends and the loved ones, and they need care. So it's really a continuum. It doesn't end when that person dies. So do not resuscitate doesn't mean do not treat or do not care.
Yes, it's definitely not a black and white situation. There's a large gray zone in between. Well, very, very fine answer. What do your fellow EMTs and paramedics think of this program?
I think almost universally they approve of it. I think early on there was some skepticism because it was a new thing and people are unsure about new things. But I think almost universally the feedback that I have gotten has been very positive. And I think what's interesting is that it sort of gives the EMTs and the paramedics permission to spend more time on scene on some of these calls, to be with the family members and be with that person who is perhaps dying or who has already died. And some of the feedback that I've gotten is that some of those calls end up being some of the more memorable calls that people have been on in their whole career, which is not what an EMT would expect at the beginning of their career. They expect they would be thinking of these dramatic calls that they've been on over the years, and certainly those make an impact also. But some of these calls where you assist family members as a patient is passing, those end up being very meaningful calls.
Yes, I can certainly see that. What has been your experience with family members? Also
extremely positive. Both at the scene, I have gotten many hugs and much appreciation from family members at the scene when they realize that they've called for some sort of help. They often don't know what help they need. And this is one of the questions that comes up sometimes is, well, why do people call 911 if they don't want a resuscitation? And it's because they just want help. They want someone to help them through this process. And so the feedback that we've gotten as we have helped family members and helped patients through this process has all been extremely positive.
Have you noticed any changes since the program began, either changes in the perception about end-of-life care or any other aspect that may have changed?
Absolutely. In the beginning, there was a lot of uncertainty about the compelling reasons aspect of the program. So the idea that you could withhold a resuscitation effort if a person didn't have written documentation. And in fact, that concern about that part of the program is part of the reason that we did the study that we did, which looked at systems that implemented the compelling reasons guidelines and compared them to other systems. So there was some anxiety about making that decision and about allowing EMTs to make decisions in what everybody agrees can sometimes be a gray area. And I think that the work that we did showed that EMTs can make those decisions. And in fact, EMTs make a lot of decisions in gray areas about whether to call a medic unit, whether a patient should be transported or can stay home. So they're making a lot of these decisions anyway. And we have been gratified that after the training that they get, that EMTs make the correct decisions. There was no case where an EMT withheld a resuscitation when they should have started one. But definitely from many, many years ago when we started this program until now, there has been more and more acceptance. And I think that's a societal thing also. I think society is recognizing more about about the rights of people to determine their health care and their end-of-life treatment. And furthermore, I think there are more resources now that are available to patients and families than there were 15 or 20 years ago. So things like hospice and home health care that can really, really help families through this process. Ideally, we would like it if people didn't have to call 911 in this situation, because it can be somewhat disruptive. But we recognize that not all families have the time to get hospice or have the resources, and so we want to be there in order to help them through this.
I'd like to point out that the Compelling Reason program isn't something that you just write a memo and it happens. There's really training involved, and Sylvia, thanks to your help, the Resuscitation Academy has a end-of-life toolkit on its website written by Sylvia with a little help from a couple other people. It's a wonderful toolkit. It goes into great detail over all the things you've just mentioned. So I want to personally thank you for starting this program. I think it's a very important part of care, and resuscitation encompasses the full spectrum from deciding when to resuscitate and being wise enough to know when not to resuscitate. So, Sylvia, any final words before we end?
No, I think I would just encourage people to consider a program like this, as long as they're willing to commit the resources to it, to get the backing of your medical community, and are able to commit resources to training. I think it's a very good service that you can provide for your citizens.
Well, I agree, and I thank you for being the catalyst to make it happen in our county. Thank you very much, Sylvia.
All right.
Bye.
Thank you.